Hello friends, welcome back to my new video in my channel. Hope you all are doing well in this 2025. And today I come with part 1 of this new exciting video based on a novel biomarker, pancreatic stone protein or PSP. And this is a particular talk which I delivered in HICS, that is Hyderabad Intensive Care Symposium, in the year 2022 in the beautiful city of Hyderabad. And the disclaimer is that I am not this Viru Sahasrabudhe from the movie Three Idiots, but I am Shrikant Sahasrabudhe. So, having said that, let us start with the topic with the definition of sepsis. And as we know, sepsis is life-threatening organ dysfunction caused by dysregulated host response to the infection. So, as you could understand, each and every word of this particular definition is important and has some bearing on understanding of the sepsis per se. And as we know that it is a multi-system and it can involve neurological system in the form of altered mentation, confusion, disorientation, respiratory system in the form of ARDS, hematological system in the form of DIC or thrombocytopenias. Renal system can be affected in the form of oliguria, high creatinine, and so on and so forth. Liver in the form of high bilirubin, and cardiovascular system, of course, in the form of hypotension, mottled skin, increased lactate shock, etc. So this definitely a challenge, and as you could see, the timeline from say 1975 or between 1975 to 80, the incidence of sepsis is gone up exponentially. It is per lakh population, and what is heartening to see is that the hospital mortality of sepsis over the time is actually coming down. So if you see 1990 or 90 or 95, you could see that the mortality is definitely down when you see this graph which is in 2010. So what does that mean? That of course we need to have a good understanding of sepsis, and we have had changes in our understanding and thought processes and approaches, which were probably effective against this deadly disease. So as we know that sepsis, it can be interchangeably called as bacteremia or bloodstream infections. As I said, it's a dysregulated host response culminating into organ failure, circulatory collapse, and metabolic deteriorations. And with this particular article by the famous Kumar et al., which clearly showed that the antibiotics which were administered within 1 hour of the admission to the hospital, there was a 7.6% drop in the survival with the delay of this antibiotic beyond 1 hour. So it is extremely crucial and important to deliver antibiotic within an hour of the arrival of the patient in the ER or the diagnosis of sepsis as such. 20 to 30% of septic patients who actually get inadequate antibiotics have high mortality. And there is a problem of empiric broad-based or a broad spectrum antibiotic which can mount towards antimicrobial resistance. So we as intensivists have a very important role to play to avoid the misuse or the overuse of antibiotic, but at the same time delivering appropriate empiric antibiotic to any septic shock patient who arrives in ER, with the aim of decreasing the mortality of this patient. And what does the surviving sepsis campaign guidelines recommend, which is clearly the empiric broad spectrum therapy with one or the more antimicrobials for patients presenting with sepsis or septic shock to cover all the likely pathogens. It includes bacterial, potential fungal, and viral organisms as well. Now, for this, we need to have the test, but as we know that the antimicrobial susceptibility test will take some time, and we need a test where the TAT or the turnaround time should be as least as possible for us to identify the microorganisms and at the same time know the drug sensitivity as well. So the rapid diagnostics are at the horizon. We are already at a time where we have biofires and all sorts of multiplex PCRs, and that is giving us the reports within few hours, which will be obviously responsible for whether de-escalation is to be done. And for that, we also kind of look upon whether there is any biomarker which can help us to kind of suspect a bacterial or any other infection. And probably that is the reason why this topic is important, as we know that there are several others uh, parameters with which we can actually suspect patient having infection or sepsis, be it be a WBC count or the signs and symptoms of the patient, and traditionally and conventionally the blood cultures which we send. But the challenges are that they are positive in only 20 to 30% of the patients, and importantly they will take around 2 to 3 days before the real results are available. So we have come out already with a few of the biomarkers of late, and we are probably exposed to procalcitonins, the C-reactive proteins, the cell-free DNA, and so on and so forth, where the challenges are still haunting us. And what's the problem with these kind of biomarkers is the sensitivity and the specificity which we need to look at. What is the concept is to start the antibiotics, right? That is what we discussed. Why do we want to diagnose sepsis? Because we need to administer antibiotics or the suitable antibiotics, and the target time is about 1 hour. For the patient who has severe VAP in a stable patient or a stable patient with a confirmed infection, the target timeline is that they should get antibiotics at least within 8 hours. And the stable patient with a suspected infection, the target time actually gets a little prolonged to about 24 hours. But importantly, we cannot actually forget this category of the patients who come in with hemodynamic instability, the neuromeningeal symptoms, neutropenics, and the patients with splenectomy. So this is a kind of category or the group of the patient who are at very very high risk of developing infection. And as you could see here that you could see that the in-hospital mortality will go up with every 1 hour delay of the antibiotic, and that was the Kumar et al. Paper which we are talking about. So this is the likelihood of infection in patients with presumed sepsis at the time of ICU admission, and as you could see that the probability of having a definitive infection is actually quite less, but the zone of the probable or the possible infection is still the same. It is a significant kind of proportion where we need to actually concentrate upon. And of course, these are the definitive infection, be a lung infection or abdominal or bloodstream, urinary tract, and soft tissue, skin and soft tissue infection. So, what are we looking at? We know that the conventional cultures will take at least 2 to 3 days. We know that there are multiplex PCRs available, but can we have something else which can complement and help us to diagnose a potential sepsis or a bacterial sepsis patient? So we look upon to the biomarker. And what is biomarker? It is a characteristic objectively measured and evaluated as an indicator of normal biological processes, the pathologic processes, and the pharmacological response to particular therapeutic intervention. So biomarker is a quantifiable measurement of biological homeostasis that defines what is normal, therefore providing a frame of reference for predicting or detecting what is abnormal. And to date, or in our literature, there is a mention of about 3000 biomarkers for sepsis and about 15 biomarkers for myocardial infarction. Talking about the point of care testing for sepsis, so as we know that the biomarkers currently measured for investigation of sepsis are generally measured in the central lab, and usually they are performed on a large automated clinical chemical analyzers, and there is inherent delay to obtain the result. So there is always an interest to have a point of care testing device which can provide us to the results within less time and as early as possible, where one of them is lactate, which can be measured on the portable POCT device along with the ABG analyzer, and which we are using day in and out. So this actually leads us to think about what are the different diagnostic biomarkers for sepsis we have at present point in time. So starting from CRP, the PCT, the IL-6 which we rampantly used in COVID, the SUPR, the proadrenomodulin, the presepsin, the lipopolysaccharide binding protein, and so on. So probably this is the last slide of this particular video or the part 1, and I will discuss a bit on pancreatic stone protein in detail in my next video. That's all for now. Tata, bye bye, take care.